Welcome, folks. We've just opened up the room and we're just going to give another moment just as people sign in. We have over 400 people who signed up to join us today, so welcome. So welcome, everyone. My name is Dr. Samir Sinha. I'm the Director of Geriatrics at Sinai Health and the University Health Network, and I'm also the Director of Health Policy Research at the National Institute on Aging. We want to welcome you today to our NIA webinar on vaccines for older Canadians, really providing today an update on what everyone needs to know to enable healthy aging. So welcome. Just want to make sure that everybody knows that today everybody's microphones are muted. But if you do have any questions for our speakers, you can use the Q&A box that you have on your screen. And at the bottom of your screen, you'll see the Q&A box, which you can use to ask any questions you have of our speakers. And if you have any technical issues or want to share any other information, you can do so in the chat box as well. So thank you again for joining us. We just want to start by acknowledging that the National Institute on Aging, which is based in Toronto, is in the Dish with One Spoon territory. The Dish with One Spoon is a treaty between the Anishinaabe, the Mississaugas, and the Haudenosaunee that bound them to share the territory and protect the land. So subsequent Indigenous nations and peoples, Europeans, and all newcomers have been invited into this treaty in the spirit of peace, friendship, and respect. So welcome. So today's webinar is really going to be an opportunity for us to share with you just an update over what people need to know around the latest on vaccines that are now available for older Canadians. You may have seen today that the NIA launched its new series of pamphlets, one specifically looking at COVID-19 vaccines in older Canadians, but then another one just giving a broad overview of what we're going to speak about in this webinar today. So we're really thrilled that in accompanying today's launch of those resources, you'll see links to those being provided to you in the chat. I also have two colleagues and friends, Dr. Vivien Brown and Dr. Allison McGeer, who will be joining us as well for a conversation and to also to be able to provide their expertise and answer some of your questions as well. I'm going to introduce my colleagues a little later in this sequence, but first of all, going to start with a little presentation just to give you an overall view on what we now know about vaccines for older Canadians, what's available and why they're important. We're then going to invite our guests, Dr. Vivien Brown and Dr. Allison McGeer, and then we'll also invite you to ask any of us questions as well. So I want to start sharing about what are vaccine preventable infectious diseases of concern for older adults. And when we talk about things that are vaccine preventable, we're talking about things like COVID-19, influenza, but also pneumococcal disease and the bacterial versions that cause pneumonia, respiratory syncytial virus, shingles, tetanus, and diphtheria. So a growing laundry list, if you will, of important vaccine preventable diseases. And the key is these are vaccine preventable infectious diseases. So we have vaccines available, but I want to share with you a little bit more about this. So when we think about what are the top 10 causes of death in Canada in 2021, we see that COVID-19 was the fourth leading cause of death, but also influenza and pneumonia as well. And you could also couple with that RSV infections, and you realize that two of our top 10 causes of death are really attributed to many vaccine preventable conditions. So when these are things that we can actually do something against, there's a real opportunity for us to take notice as well. When we think about COVID-19 in older Canadians, we know that older Canadians can present with COVID-19 symptoms differently or have less common symptoms as well. And this is really important because while we might traditionally look for typical typical presentations and symptoms, we know that ultimately the negative impacts of COVID-19 are most keenly felt amongst our older population. And amongst Canadians 60 years and older, we know that they made up 70% of Canada's COVID-19 hospitalizations and 92% of Canada's COVID-19 deaths. And while certainly we're not seeing as much of the negative impact related to COVID-19 as we did during the early days of the pandemic, especially when we didn't have vaccines, these are the current up-to-date numbers from Health Canada showing that even though many people have been vaccinated, 97% of older Canadians have received at least a dose of COVID-19 vaccines, we know that we're still seeing high rates of hospitalizations and deaths occurring in this population. And so a real need to stay updated with our vaccines around COVID-19. When we think about flu, pneumonia, and older Canadians, we also know that on an annual basis, those who are 65 and older represent 43% of our pneumonia-related emergency department visits. They represent a significant volume of hospitalizations related to pneumonia as well. And when we talk about the deaths that occur annually from influenza and pneumonia, we know that 90% of our total deaths from these conditions are again amongst those who are Canadians who are 65 and older. So again, real common issues that we need to be aware of, because sometimes people think that the influenza is just the common cold, but it can be deadly. And often we know that pneumonia is something that is quite common amongst older Canadians, and why something that we need to know. There are often many things we can do to prevent pneumonias as well. When we start thinking about RSV, this is something that really hasn't been on the radar of many Canadians until more recently, and partly because we now actually finally have something to actually prevent RSV. RSV is another respiratory virus that's quite common, especially during cold and flu seasons. And we know that when we start looking at the impacts it can have, we know that it can have different impacts across the age spectrum. So we know that when we talk about people who are younger than 5 years of age, we certainly see a high rate of hospitalizations in a younger population, but we don't see we only see a very small minority of actual deaths that occur in our younger population. What we see amongst older people is that this is the population where we see the vast majority of deaths occurring. And so while we often think about RSV as something that's a common issue in young children, the good news is for young children, it doesn't lead to that many deaths. The key is for older people, while they represent a minority of the hospital-attributed RSV hospitalizations, they still are at a greater risk of death. In fact, 1 in 9 of those who've been hospitalized from RSV have unfortunately died. And overall, older adults represent 85% of deaths from RSV that occur each and every year. So why we need to think about the importance of RSV in older populations, and why we should pay more attention now that we have something available to prevent RSV infections as well. The key is people start asking the question, okay, we know that COVID-19 is a pretty bad virus, but what does RSV, how does it compare against influenza? And when we start looking at issues like respiratory complications, or the risk of cardiac and other complications, or hospital readmission, or even death, this is a chart that really compares what the impacts of RSV are versus influenza. And you can see they're quite similar overall. And so if we're taking influenza seriously, we need to take RSV as equally as seriously as well, especially now that we actually have things that we can do to help prevent RSV infections. So it helps to understand that when we see the burden of influenza in our society each and every year, we have to remember that RSV likely has a similar burden. We just haven't done a really good job of keeping track of RSV infections and keeping as good data, partly because we had nothing to necessarily treat an RSV infection other than what we call supportive care, and we never had a vaccine until recently as well. When we talk about shingles, we know that shingles infections are really an unnecessary burden on older adults, and it's caused by a reactivation of the virus responsible for chickenpox infections, and it happens more commonly during periods of stress in older adults. Virtually every person has probably experienced chickenpox in their early lifetime, especially if you're an older person. And so we know that older adults are all susceptible to getting a shingles infection later on in life. And we know that in particular, older Canadians are more likely to experience higher rates of shingles infections, but also complications like prolonged severe pain, or what we call post-herpetic neuralgia, but also hospitalizations and death. And that's why we start emphasizing the importance of thinking about shingles in people who are 50 and older. Finally, when we start thinking about things like tetanus and diphtheria, again, it's something that we're often used at younger ages to get these shots as children, for example, but we know that it still remains an issue amongst older people as well, in fact, all throughout the life course. And we know that these infections can lead to serious outcomes. And we know that unvaccinated older adults have the highest death rates, most likely because people are used to getting these vaccines at a younger age, for example. But people forget that, as we get older, every 10 years we should make sure that we're up to date on these vaccines as well. But often we don't pay attention to the fact that we need to keep getting vaccinated throughout our lifetime as well. And that's why we see unvaccinated older adults tend to have the highest death rates, because that's where we see the lowest vaccination levels against these common issues as well. So the question is, why are older adults at greater risk to respiratory and other infectious diseases? We know that there's a few different reasons. We know that as we get older, our immune systems, start to have declines in their overall immunity. So our ability to mount an immune response, and that means that we're more susceptible to infectious diseases as we get older. I like to think about our body and our systems incurring more mileage as we get older, and so they don't work as effectively when we're younger, especially as adults. We also know that as we age, our lung tissue starts to also age, and therefore it can be harder for our lungs and our respiratory system to equally fight off and repair itself in response to a respiratory infection as well. And we also know that when we are living with chronic illnesses, for example, that can make us more susceptible to infectious diseases, partly because it can weaken our immune system, but also it can weaken our ability to protect ourselves against infectious diseases. And when people are living not with just one, but multiple chronic health issues, for example, that can also put us at increased risk of having negative outcomes from respiratory and other infectious diseases. So we know that right now, vaccine preventable infectious diseases have been associated with many medical conditions as well. So not only do underlying chronic health conditions put us increased risk to the negative outcomes from infectious diseases, but also if one does get a infectious disease, it can also be associated with more negative outcomes as well. So we know that having these underlying medical conditions like heart conditions, respiratory conditions, even cognitive impairment and diabetes, all can put us increased risk for negative outcomes from infectious diseases. But also infectious diseases can worsen these conditions as well if we were to get infected. And so this is a chart that shows this circle, if you will, looking at that risk of severe complications can increase with age and medical conditions. So if you go to the right side, for example, you can think about if you have underlying what we call comorbidities or chronic conditions, for example, like the ones we talked about, it can make you increasingly susceptible to certain infectious diseases. And those certain infectious diseases can more negatively impact those chronic health conditions. So if you have underlying heart disease, for example, it can put you at increased risk of suffering cardiac complications like a heart attack, for example. And that's why, or if you have underlying lung disease, for example, it can put you at increased risk of having what we call a COPD exacerbation, for example. So it can destabilize those underlying chronic conditions and further jeopardize one's overall health. And that's why we want to kind of break the cycle wherever we can. And we also know that certain viruses, reinfection can be common. And so sometimes if you get infected, for example, you can have what we call incomplete and short-lived immunity, and therefore you're more likely to get recurrent infections throughout your life. And so certain populations, such as those who are immunocompromised, have more risk of reinfection. And RSV is a classic example where where most of us would have had our first RSV infection as a young child or an infant, for example. But then it's not uncommon for us to get reinfected multiple times throughout our life course, partly because it's not that you get the infection, you create antibodies, and you're immune for life. Often that immunity might be incomplete and short-lived, and therefore that's why there's an important aspect of recognizing that we don't always have lifelong immunity, and why it's important to keep up with things like vaccinations for various diseases as well. So how are things looking overall when we start thinking about respiratory season? Because we've heard about this concern about the idea of a triple-demic now that we have COVID-19 in the mix, but also things like influenza and RSV. And the key thing to note is that when we look at the data between 2014 and 2020, the orange line represents kind of the typical seasonal wave or activity that we see from respiratory syncytial virus or RSV. The blue line represents influenza activity. And what you can see is really, starting in the late fall and right up until May, you see there's quite a bit of typical RSV and influenza activity. And this is what we typically call respiratory virus season. Sometimes people think about seasons being, fall, winter, summer, spring, but you can see this kind of extends through fall, winter, and spring. Is what we'd call, kind of a respiratory virus season in particular. So this just reminds us that while people think that sometimes, oh, if I miss my chance of getting my influenza vaccination or my respiratory vaccines in October or November, is it too late? Absolutely not, because this season goes all the way until May. We also, as I was mentioning, have talked about this idea of a triple-demic when we start thinking about COVID-19, influenza, and RSV. And certainly we knew that last year during our respiratory season, we saw activity of all three viruses acting around the same time, and that certainly put a lot of pressure on our healthcare system, but also in general on the health and well-being of older adults. And so that's why we always want to think about the importance of making sure that against the vaccine preventable viruses, what is it that we can do, not only just vaccinations, but other public health measures that we can help protect ourselves during this season to try and avoid the consequences of a triple-demic. And right now, when we start looking at what activity has been looking like since September 2023, we know that we certainly have seen quite a bit of COVID-19 activity coming into this respiratory season, and so far there hasn't been that much RSV or influenza activity, although we're just at the start of a traditional season for both RSV and influenza, and our expert, Dr. McGeer, can certainly tell us what we're actually seeing, on the ground from where we were just a few weeks ago, as opposed in terms of this chart. So we can see that right now we've seen a lot of COVID-19 circulating, but we're right at the start of our traditional influenza and RSV seasons. So something that we need to keep in mind. So why are vaccines important to enable healthy aging? We know that, as we said, our immunity tends to weaken as we age. vaccination helps to prepare our bodies to fight vaccine-preventable infections. We know vaccinations can also help us protect others. And so if we're less likely to get sick, then we're less likely to cause others to get sick. And that's what we talk about, the importance of things like herd immunity and making sure that if we don't get influenza, for example, we're less likely to pass it along to other people who may not be able to get vaccinated or whose immune systems are at increased risk for negative outcomes. We also know that vaccines have certainly eliminated certain deadly diseases, and they can be incredibly effective. Not every vaccine means that you're going to actually not have, get a certain infection, for example, but it can certainly lower the risks of negative outcomes, and that's why they're so important as well. And so our acquired protection, even if we do get vaccinated, that protection can weaken over time. That's why some people say, Dr. Sinha, do I need yet another COVID-19 vaccine? I hear that they're available this fall. There's a new formulation, but I've already had a number of doses. Do I really need another one? And the key answer is that really our acquired protection can weaken over time. And that's why we're recommending, especially if you're an older person, that people get the latest version of the COVID vaccine, but make sure that we also keep up to date on our other vaccinations as well. Hence why we recommend, for example, tetanus and diphtheria every 10 years. And vaccines are an incredibly safe option as well. Right now, we know that after administering, tens of millions of doses of COVID-19 vaccines, but also other vaccines, we know that they are incredibly safe. And in order for a vaccine to be approved in Canada, they have to go through rigorous approvals by Health Canada before anything is allowed to be used in our broader community as well. So they're incredibly safe, they're incredibly effective. And this is why we want to share with you the latest information about what is available as well. So right now we have updated and new vaccines have been approved in Canada, more recently for COVID-19, influenza, RSV, and pneumococcal diseases. And right now we know that when we look at our recommended vaccines for older Canadians, right now we know that the current recommendation is that that everybody, especially if you're 65 and older, but people 6 months and older, get the latest version of the COVID-19, which is what we call a monovalent. So it has a single strain of the latest form of Omicron that has been circulating around. It's available free of charge. And it's been available for well over a month now. We're also recommending that everyone get their annual influenza dose. So right now, our Public Health Agency of Canada wants 80% of older Canadians. I want every older Canadian to receive their annual dose. And again, these are available free across the country. And if there is an enhanced dose available, and that could be one of two types that are commonly available, a high dose version or what we call an adjuvant version. They're both pretty much equally effective, and we're recommended over a standard dose. So if you're an older person and you're going for an influenza vaccine, you can say, is there an enhanced version or a version made for older people? And your provider will know what you're talking about and make sure that you get one that's specially formulated for older adults. But even if you can't, if they say we're completely out of those right now, a standard dose is perfectly fine. It's just better if you can even get an enhanced dose and if it's available as well. When it comes to RSV, this is a brand new vaccine that is now available. It's a one-dose vaccination. It was approved by Health Canada in August. There'll be other RSV vaccines we anticipate coming to market over the coming year, but basically, it is currently free only in Ontario and specifically only for those living in long-term care homes, elder care lodges, or certain retirement homes. Everybody else across Canada has to be able to pay for this. But the good news is that some private drug plans, if you're lucky to have one, are covering the costs as well. So again, this is now available across the country. It's a one-dose vaccine, but it unfortunately is not covered except for certain populations in Ontario. In terms of the pneumococcal vaccine, this is a one-dose vaccine that is available. And right now, Prevnar 20 is the vaccine that is being recommended by our National Advisory Committee on immunization. But the key is that it's not free everywhere in Canada. In select populations, for example, in Quebec, it is available and it is publicly covered. And some private drug plans might cover it. But there is a free version called the PPV23 that is available. So if you've never had a vaccination before, you don't have coverage, then again, you can get the one that is free and available across Canada generally, called the PPV23. Otherwise, the latest one being recommended right now is Prevnar 20, and we have more guidance available for you to help understand, if you've had previous pneumococcal vaccinations, what you can get and how to get it. We talked a bit about shingles, and shingles is a two-dose vaccine, or the latest version called Shingrix, the one that's being recommended. It is a two-dose vaccine. There's an older vaccine that is a single-dose vaccine, and that's available free for certain age groups in Ontario, PI, Quebec, and the Yukon as well. And then, as I mentioned, there is the tetanus and diphtheria vaccination, and this is one that we recommend that people get every 10 years as well, and there's varying coverage available across the country for this. So the key is that right now, we know that our big challenge across Canada is there's a lack of awareness amongst older people about the vaccines that they are eligible for, and the ones that are even covered as well. And so the red lines on this chart show that our goal is to try and get at least 80% of older Canadians vaccinated against their annual influenza, with their annual influenza vaccination or their one-time pneumococcal vaccination. But we haven't done a very good job. And for vaccines like shingles and others that aren't necessarily covered uniformly across the country, we know that we've struggled to really get more people vaccinated as well. And we certainly know that cost is a barrier, but also access and availability are barriers as well. So we need to do more to raise awareness and also make sure that we do have more public coverage available so that we try and minimize the barriers for people to get vaccinated as well. But the good news is that 96% of older Canadians have completed a primary series of the COVID-19 vaccine. So we know that older Canadians are not vaccine hesitant individuals. We just need to do a better job to help people improve their uptake of their other recommended vaccines as well. And so not only do we want to recommend that people stay up to date on their vaccines, we want to remind people that they can get multiple vaccines at the same time. And so most vaccines can be safely administered at the same time together. And so you can certainly ask your healthcare provider what vaccines you might be eligible for and which you could be safely co-administered to make it more convenient for you to stay up to date with your recommended vaccines. And so, as I mentioned, there's a lot of information that I presented to you, and sometimes it can be confusing, and sometimes everybody's got individual questions. Wait, I've had this, what's covered, what do I need? And so what we've done through the NIA is we've actually put together a pamphlet that actually helps to explain all of what I've just talked about in a clear and easy to way format. And we've also translated these into 18 different languages as well. So we want to make sure that people have clear, easy to read, accessible information that makes sense and that can help them navigate their journey to stay healthy and make sure that they can stay up to date with their vaccinations as well. We've also, in 2021, we created this pamphlet called COVID-19 Vaccines, What Older Canadians Need to Know. And we found that many people had found this quite helpful and a very useful resource, especially when we had it translated into multiple languages. So we've also translated this into 18 different languages and fully updated it with the latest information around the COVID-19 vaccines so that people can have all their questions that are often common questions that others are asking available as well. So I'm going to stop there, and I'm going to invite back our colleagues to join us now as well. So I'm going to invite Dr. Vivien Brown and Dr. Allison McGeer to join us here, and I want to now introduce them more formally as well. Dr. Vivien Brown is a family physician and author in Toronto. She is currently appointed to the Department of Family and Community Medicine at the University of Toronto as an assistant professor. Her major interests are in the areas of health promotion and prevention for women and continuing medical education, adult immunization, and vaccine-preventable illnesses. She is the past president of the Federation of Medical Women of Canada and is the immediate past vice president for North America for the Medical Women's International Association. Recently, she was named one of Canada's most influential women by the organization Women of Influence for her work on advocacy on HPV, on the HPV vaccine for Canadians. And her most recent book is called The New Women's Guide to Healthy Aging. I also want to introduce Dr. McGeer. Dr. McGeer is a professor of laboratory medicine and pathology at the Dalla Lana School of Public Health at the University of Toronto. She's also a senior clinician scientist at the Lunenfeld Tannenbaum Research Institute, and she's also an infectious disease consultant at Sinai Health System. Dr. McGeer, as I mentioned, is an infectious disease physician epidemiologist and a colleague of mine at Sinai Health, and she has been a member of Canada's National Advisory Committee on Immunization, also known as NACI, and is a current member of NACI's Influenza and Pneumococcal Working Groups and on the Ontario Immunization Advisory Committee. Much of her research focuses on viral respiratory illnesses in adults, and she has more than 90 COVID-19 related publications and has served on a number of provincial, national, and international science advisory groups during the COVID-19 pandemic. So you can see that I couldn't have chosen two smarter and more capable folks than myself to help join me this morning. Dr. McGeer, Dr. Brown, welcome. I just wanted to kind of ask both of you just some questions before we get to the audience. And I see that we've got a number of questions that have come into the chat, which is great. So I want to just start, first of all, I mentioned a little bit about its respiratory season that's coming up. And Dr. McGeer, can you give us a sense of kind of what we're seeing? Often people hear about this idea of a triple-demic. Right now, certainly there's been a lot of COVID-19 circulating, but what's the trend, or what are we seeing when it comes to influenza and RSV? You know, how concerned should we be?
Well, you know, I think one of the good things pre-COVID pandemic was you didn't have to spend all your time worried about when the next wave of COVID was going to be or when viral respiratory season was going to be. But as you just pointed out, if you're an infectious disease physician, if you're a public health person, you know that viral respiratory diseases come in the winter and they have somewhat different patterns. And there's also some variability year to year. So starting in August or September, public health people across North America are watching indicators of positive tests and illness coming to judge when the season is going to come. Last year, as you pointed out, because we were catching up from not having had flu and RSV during the worst of the pandemic, those seasons came early. This year, they're back to looking regular. So we're just beginning to see RSV activity go up in children, which is just about when we would expect it for this time of year. And we know that RSV activity in older adults is usually between the middle of December and the middle of February. And that looks like it's on track. Similarly, last year, even at this time, we were having a lot of influenza activity really early, almost unheard of. This year, again, we're just beginning to see influenza activity start. So that tells us that we're expecting it to be a kind of a usual influenza season again, starting middle of December, being at its worst, sadly, over the holidays, just when it can be most disruptive, or at least that's the way it feels, and then going on into January and February. So again, we come back to, if you're a public health person, you're watching for exact things. People who run emergency departments of hospitals worry about exactly what the pressure is going to be. For all of the rest of us, it's just you need to know that respiratory viruses come in the winter. So you want to start to be protected for them at the beginning or middle of November. And then that protection will carry you through until February or March. As you've pointed out, If you're a little bit late getting your vaccines, don't get them until the beginning of December. That's okay. You've still got lots of the season to go, and you'll still get a lot of protection.
Thanks, Allison. And then when it comes to right now, when folks are thinking about this question about, okay, we just talked about a bunch of vaccines available in respiratory season, for example. People say, look, I haven't gotten anything. I just am too busy. I'm now convinced. But what do I start with first? This is a question some of my patients say, what would you recommend if there's any sequencing at all? What advice would you give to our viewers about what order and how might people want to approach this?
So at the moment, there's a lot of COVID activity, but not much flu or RSV. But there's also, you got to think about, there's 4 vaccines you want to get if you can do it. Okay, flu, COVID, RSV, pneumococcus, because the pneumonia is a complication of all these viral infections. So you want to add that too if you can. You've got 4 vaccines to get and a month or maybe 3 weeks to get them in. So I would definitely start with COVID because there's a lot of COVID activity and the other ones are coming later. And because you can get 2 vaccines together, if you want to get all this in, COVID and flu together makes a lot of sense. We've got a lot of experience with getting COVID and flu vaccines together. And then if you wait a couple of weeks, then you can get your pneumonia vaccine and your RSV vaccine at the same time. So you can, in a period of a little over 2 weeks, you can get all 4 vaccines if you want to do it that way. Also okay to spread that a little further if you choose to and get them, one at a time at 1 week intervals. It's a little bit more travel time, to get the vaccines, but that also works just fine.
Perfect. And Dr. Brown, you're working, I know you're in your lunch break at your clinic right now, and you're busy during the season. How are you approaching kind of the, co-administration, or even kind of, practically, like, how would you counsel your patients around co-administration, or thinking about how they're getting in, and any observations you've seen from this perspective, and in terms of how you're approaching that?
Yeah, well, thank you. Thank you for having me here. It's really a pleasure, Samir. One of the things that I think patients are beginning to understand, and I think we as physicians are beginning to understand, is this ominous feeling that winter is coming. We saw that with Game of Thrones. They kept saying winter is coming. And what we really know is these viruses and pneumococcal pneumonia all come together. So as I'm seeing patients in the office right now, as of this morning, I'm trying to get everybody immunized as quickly as possible. Now, most people, when I see them, have already had something. Maybe they had COVID in the pharmacy, or maybe they had a flu shot at work. And so part of it is going through in detail what someone has had, and then filling in the blanks, filling in the pieces of what they need. I'm careful that I don't want to administer 2 vaccines that are adjuvanted or that have irritants. And so, for example, I wouldn't administer shingles vaccine and RSV together, but most vaccines you can administer together. And even shingles and RSV is safe. It just causes more side effects. So people are not going to be very comfortable the next day or 2. So if somebody needs it and they're about to go away for the next 6 months, I would give them everything all at once if they needed it. If you can spread it out, they probably will be more comfortable in terms of reactogenicity the next day, or what we call some of the side effects that some people experience. But everybody's situation is different. I'm looking at their chart. I'm going through what they've already had, what they need, and they may have already had PCV20 last summer when I was seeing them for something else. And so I'm trying to fill in the blanks and get people up to date before the end of November. Allison gave us a little bit of leeway and said it's okay if you get it in December and January, but it's better to get it now because it takes about 14 days for these vaccines to react in your body, and we want you protected. We want you protected for this ominous winter is coming.
Perfect. And then we've obviously spent a lot of time talking about vaccines so far, but other advice that you're giving your patients right now about, again, other public health measures or things they can do, because I think people have heard, like, do you mask? Do you not mask? Should I be gathering with people? I'm a bit nervous because we're entering respiratory season. What practical advice are you giving your patients?
Well, what I remind people is that in the winter of 2021, we were still being exceptionally careful with hand washing, masking, staying out of social situations indoors. And we did not see much flu and RSV in that year because those public health measures do work if everybody does it. Not everybody is following all the advice, but for an individual person, I really do encourage them to pay attention to hand washing, to absolutely wear a mask in a social situation where there's a lot of people. And in my office, the doctors, the front staff, and all the patients are wearing a mask all day long. So if you're a vulnerable person, if you're in your 80s, if you've got underlying disease, if you're immunocompromised, you want to avoid those big crowded situations, and you do want to wear a mask when possible. If you're sitting and eating with a colleague, you can't wear a mask. You're taking off your mask to eat. Of course, that's normal, but you're trying to decrease your exposure. You're not eliminating exposure.
Perfect. Okay. We have a very, we've got lots of questions that have come in the chat. So I'm going to now pepper our two experts with some of these questions, and I'm going to direct them accordingly, but I appreciate whoever wants to tackle can tackle as well. But here's one question, Vivien. If it says, if someone's had the Prevnar 13 and the Pneumovax 5 years ago, should they get the Prevnar 20 now for extra protection?
So that's a great question, and I think it's a fair question. And happily, we've got good Canadian NACI guidance. NACI is the National Advisory Committee on Immunization. NACI gives us national guidelines as to what to follow. And absolutely, if you've had Pneumovax and PCV13 5 years ago, you should get PCV20 now. The serotypes that Pneumovax was protecting you for have already worn out. That Pneumovax protection doesn't last very long. It's a polysaccharide vaccine. It gives you short-term antibodies, not long-term antibodies. What the American guideline says for PCV20 is one and done. And really what that suggests is when you get that PCV20, you don't need another pneumococcal vaccine. And unless the information changes and evolves over the next few years, you probably won't need another vaccine for pneumonia, for pneumococcal disease. So yes, if it's 5 years, you want to get it. You want to get PCV20. And I'll go one step further to say, if you just had PCV13 by itself a year or two ago, you absolutely want to get PCV20 and pick up those extra 7 serotypes. PCV13 is an excellent vaccine, but it covers 13 serotypes. And we know by our data and watching Canadian impact data that the other 7 serotypes are really important, and they're in PCV20.
Perfect. Allison, we have this question from someone saying, look, should older adults who have comorbidities or multiple comorbidities get the COVID vaccine every 4 months to prevent infection, as opposed to, say, every 6 months is being recommended? So what should the interval be for them? And they said, given the risk of post-COVID syndrome, worsening dementia, false frailty, not just preventing hospitalization and death, who would we recommend maybe go sooner than every 6 months?
It's an excellent question. I think it's a two-part thing. I think, first of all, many of us are really hoping that, one COVID vaccine this fall will carry us through the whole year, not just the next 6 months. But it's also true that older adults, particularly frailer older adults, are the people who are at much more at risk. And there may be some benefit to giving them additional shots, which is why last year, after our bivalent booster in the fall, it was only older adults that were recommended to get the second dose of bivalent booster in January and February. So I think the good news of where we are now is that every time you get another COVID vaccine dose, your antibody levels go a little higher and they last a little longer. So we started out with our frailest, oldest adults saying and immunocompromised people saying you really need a dose at 3 months. And now we're looking at how long those antibodies last and say, well, not so fast, probably 6 months, with an exception maybe this fall, because XBB is a very different virus from the BA.4/5. And so it's like a big shift in the flu vaccine for 1 year, right? That we had a big shift over the summer in COVID. And so that booster is important, but it's probably going to last us at least 6 months and maybe even a year now, just because of the accumulation of antibodies that you get from having repeated doses of vaccines. So there's not harm in getting a vaccine dose a little bit earlier if you can get it, particularly if you're going to take on some really high risk activity like, a world cruise, or some really high risk thing. Getting a dose early is a fine thing, but most of the time now you don't need it.
Perfect. And then a follow-up question. Someone said, I heard Moderna was more effective than Pfizer. Is that true for COVID-19?
So it was true with the original doses for very frail older adults. So we think just because the Moderna had a higher dose than the Pfizer, when you got to the most frail of people, you could actually see that antibody levels were a little bit higher with Moderna and protection was a little better. And that's why we shifted to offering Moderna specifically to people who lived in long-term care facilities. For adults under the age of 70, for generally healthy people, the differences were really small and we're not that worried about them. Since then, however, the dose in the Moderna vaccine has come down because that reduces the number of adverse effects you get from it. So now they are probably much more equal, and there's really nothing to distinguish between them in terms of this fall's vaccine.
Perfect. And then, Vivien, I'm sure you have this question, or as even Allison was saying, look, if you have a big world cruise that you're planning to do, you might want to really make sure you're up to date for vaccine. So someone asked, how long does it take to get effectiveness, say, from the RSV vaccine, or maybe even any of the other ones? So if someone's saying, look, I've got this big, world cruise coming up in a month's time, do I get it the day before, or do I need to get it a month before? How soon do these things take effect?
Most of the research says it takes about 14 days to get a full immune response. And so you don't want to get it just the day before you go. The other thing is you don't know if you're going to be that odd person that gets side effects like a low-grade fever, where you may have to stay home and you're just concerned about the side effects and how you feel. So I would never leave it to the last minute. I'd try to get it a couple of weeks before.
And on top of that, someone's saying, look, I had COVID-19. I'm going to keep this to you, Vivien. I had COVID-19 for the first time in October 2023. Do I wait a certain period to take my COVID vaccine, or do I take it ASAP? I am 60 years old.
So a really good question. COVID itself acts like a vaccine because what it's required for you to get better is it's required your immune system to kick in. So you now have high antibodies against COVID because you've just fought off an infection. So there's no benefit getting the vaccine for at least 6 months. And that gives your own antibodies time to settle before you get another shot. So you've had effectively a natural boost in immunity by having had COVID. Not what we would recommend, but you've got 6 months now where you can sit back and you don't need a COVID shot.
Perfect. Okay, Allison, the next two questions are for you. So there's a recent paper, I think, published in the United States that was talking about co-administering the COVID-19 vaccine and the flu shot in older adults, increasing a signal or risk for TIAs. What should we take from that? Has that been proven, or should we be concerned?
It's a great question. But I think you've seen the fact that neither NACI nor the Advisory Committee on Immunization Practices in the United States nor Public Health England have recommended any change in getting these vaccines together. There have been 2 studies now that suggest, okay, really weak, that if you get a high dose flu vaccine and a COVID vaccine together, that there may be a small increased risk. We're talking 1 or 2 in 100,000 people. Okay, so if it exists, it's a very small risk. And there are 5 or 6 other studies that have not been able to see an effect at all. So there is a possibility that there is a very small risk associated with it, but it's not for sure at all. And if there is a risk, it's probably at the level of something that you really don't need to worry about.
Perfect. Okay. And
sorry,
go ahead.
Just to add to that, Samir, one of the companies is actually studying putting COVID-19 and flu together as one shot. And so what we're looking at trying to streamline this as time goes on, because COVID-19 is becoming endemic rather than a pandemic. It's becoming something we expect every year. And so there's research going on actually combining the 2 shots together.
Yeah, so the goal is that, when you're 2, 4, and 6 months old, you get, 6 pathogens together in one dose. Of course, that's what we want for adult vaccines, that in one shot you can get COVID, flu, pneumococcus, shingles vaccine, right? Ideally, age 60, one shot does all of them. Now we're a ways away from that. But it looks like flu and COVID vaccines might be the combo that comes first, and maybe even next year, probably the year after, but maybe next year.
Perfect. Someone said that, look, hey, if I've got the varicella, the Varivax vaccine, I never had chickenpox. I've now gotten my full series of the Varivax vaccine. Then can you still actually get shingles down the road?
No. So if you've not had chickenpox, and you've not had chickenpox and didn't have antibodies, and you've got Varivax, then that's one of a very small group of people who don't need the shingles vaccine, because if you haven't been infected with chickenpox, then you can't get shingles. And the varicella vaccine is not perfect, but it's pretty good at protecting you from getting chickenpox.
Perfect. Someone's asking, where can I find, the information on these vaccines that I should get topped up throughout my life? Again, there are good resources through Immunize Canada and others, but we'll make sure that we've got a link to our new pamphlets today, because I think it really gives you a sense, especially if you're an older person, kind of what you need to stay up to date on and how often as well. So just sharing that. Related to that, someone is asking, how often should an older adult get boosted with the Tdap? If you've received an adult booster at age 50 for for tetanus, diphtheria, and pertussis, should you get it 20 years later as well for pertussis protection? I guess, Allison, should I give this to you, or Vivien, do you want to tackle this?
So I'm not sure what the public health regulations are in every province, but it makes sense to me to get Tdap, because if you're now in your 70s, chances are you're going to be exposed to some grandchild. And so pertussis in young babies is a serious disease. And if your 10 years is coming up, I think it makes sense to get boosted, not just with tetanus and diphtheria, but consider pertussis as well. Maybe it's covered in your province. It's different in different provinces. If you can't get it, then take tetanus, diphtheria. But I don't see why you wouldn't want to get pertussis at the same time.
Okay.
Yeah.
Go ahead, Allison.
No, I was just going to say the same thing. I'm not actually sure why we haven't just switched out of the old Tdap into a cellular pertussis. The vaccine's not particularly more expensive, and more doses of pertussis vaccine would, I think, in general, be a good thing for all of us.
Absolutely. One person was Dr. Stark here is asking, is the non-mRNA COVID-19 vaccine available in Quebec yet, or in other parts of the country? That's the one called made by Novavax, I believe, and it's a non-mRNA version. So there's going to be 3 different types of vaccines available against COVID. Do we know if that is available yet in Canada?
Unless it snuck up on me, which has happened before. I don't think it's been authorized by Health Canada yet. It's under review. We're expecting it. People are expecting a supply, and the word was this fall, but to my knowledge, it's not yet been authorized by Health Canada. You can check online with Health Canada, because I have been known to miss things.
And what the pharmacists say is it'll have to be special ordered, because what they're having in great quantities is the mRNA vaccine, since that's what most people are getting. But for someone who, for whatever reason, does not want an mRNA vaccine, that should be a good option. I don't believe it's actually physically here in the pharmacy yet.
And I'm not sure, I'm also not sure it's going to be in the pharmacy. You may in Ontario have to go to your public health unit to organize a special order of the vaccine. So you just be aware that when it does come, your local public health unit newsletter or your local public health unit website in Ontario, I'm not sure about the other provinces, should be able to tell you how you can access that vaccine for yourself or for your patients if you need it.
We have a pharmacist who says, I'm working in the community in the GTA, and they said, what's the difference between the trivalent and quadrivalent flu vaccines, and is the difference important for my patients? Not
anymore. Okay, so there used to be, so the story with quadrivalent flu vaccines is that about 30 years ago, the strain of influenza B started drifting apart into two strains. And over the last 30 years, those strains have come further and further apart. And so now, if you're a child and you haven't had influenza B before, you get infected with one strain, you're not well protected against the other strain. And for that reason, we added the second B strain into flu vaccine so that we had two Bs and two As. During the pandemic, however, one of those B strains vanished, okay? We don't always know why this happens with influenza, but we can be capable of being grateful for it when it does happen. So the B strain called B Yamagata appears to be gone forever. Hasn't been seen since 2020 anywhere in the world. And so now you don't actually need B Yamagata in your flu vaccine. And as of hopefully next year, we're actually going back to only 3 strains in all flu vaccines. So this year, it does not matter whether you get a trivalent vaccine or a quadrivalent vaccine against influenza. As you may know, the adjuvanted enhanced flu vaccine for older adults is trivalent. The high-dose vaccine is quadrivalent. But from the perspective of influenza B strains this year, they're identical because the second strain is gone.
Perfect. Okay. A lot of folks are mentioning that, hey, after I got the COVID-19 vaccine, I experienced a stroke a few weeks later, or it seems like, you know, I have a flare up of a condition a while later, and they're genuinely saying, like, is it related, or could it be, like, what do I do if I feel that I've had 2 different conditions at the same time? How do we approach that? I think it's making them worried about their confidence in vaccines.
Yeah, you know, I think as a family doctor, I have to listen to what has happened to a patient. And if something has happened, I guess within a short time after vaccination, I would report it as a possible adverse event. It doesn't mean that I think it's necessarily an adverse event or that it's necessarily related to the vaccine. But I think we want to report these adverse events so that the experts can look at the numbers across the country and across the world, for that matter, to see if there's any data that supports some cause and effect. You know, people end up with infections every day, and people end up with cardiovascular complications every day. And when we're talking about older people with multiple comorbidities, having a shot and then 4 weeks later having something exacerbated in your general health is not necessarily related. It's not cause and effect.
Nonetheless, so at a population level, that's exactly how we do it. So you collect all the adverse events that happen to people after they get vaccinated, and you look at how that compares to how common those events are in somebody who's not vaccinated. So we know, for instance, in North America, if you vaccinate 1 million men who are between the ages of 50 and 70 on any given day, 10 of them will have a heart attack. That heart attack will be completely unrelated to the vaccine. If you don't vaccinate them, 10 of them will still have a heart attack. But it is true that if you're the person who gets a heart attack the day after your vaccine, you know, whenever something happens to you, you want to understand what caused it, right? And so you go back and you think about all the things that you might or might not have done that might have caused you to have that illness. And so there's a real sense, even if you know statistically at a population level that the vaccine doesn't cause this, it can feel like it. So that's a circumstance in which, in my view, it's not unreasonable to think about getting a different vaccine that's going to be associated with different effects. So if you feel like that's happened to you, talk to your healthcare provider, you know, figure out what you need to know, how you need to decide whether there are alternatives that you can choose where maybe even if sort of from a science basis you don't need them, it's going to make you feel better. Nothing wrong with getting different vaccines to protect you when you can.
Absolutely.
Yeah, I agree, Allison. You know, I think sometimes confidence is very, very subjective, and you want to feel confident about what you're doing and the choices you're making.
Perfect. We have been able to answer over 25 questions, and I think a lot of folks are are have really just spoke to their interest in just making sure that they've got the right information. I think the good news is that our experts have been able to put a lot of these answers together succinctly in easy to read pamphlets. And so I recommend you take a look through those. I think certainly a lot of people have brought up the fact that some of these vaccines, they're not covered, and people have to pay out of pocket and wondering, is it worth, getting these vaccines? All these vaccines that are recommended, absolutely worth it when you look at the impact that these diseases can have on older adults. But we certainly at the NIA are recommending that anything that can have significant savings for our healthcare system and demonstrates its value, like many of these vaccines do, should be publicly covered. And we want to work and advocate towards reducing the barriers for people to get vaccinated as well. But certainly do take a look through our information. And I want to, more importantly, thank our experts who've given of their time today to be with us, to answer your questions, and to make sure that we can feel more confident about what's happening. We can be more aware about what's available, and we can make sure that we know what our next actions can do to promote healthy aging. So I want to sincerely thank Dr. Vivien Brown and Dr. Allison McGeer for joining me today. And we want to thank everyone for being a part of today's webinar. And we want to wish you all a great rest of your day.